Dear colleagues, this is another soft cataract dot in subconjunctival anesthesia. Incising the anterior capsule with the knife after doing the paracentesis and using the grease rubber forceps is very easy to fashion around small capsular axis, in this case 5 millimeters or so. We have a closed angle glaucoma in early stages of the disease, and the patient opted for multifocal IOL, and we're going to place a trifocal IOL from Zeiss. The cataract is pretty soft. It's pretty much an aspiration that is done. I'm using in this case kuatera Phacomachine from Zeiss. Finishing up the capsular axis should not be left under the main incision from which you do the capsular axis, because it's harder to reach, but we are able to finishing the capsular axis, enlarging it a little bit there on 6 o'clock area, and then using a cannula we do the hydrodissection and hydrodelineation. Having the main paracentesis, placing the viscoelastic inside the anterior chamber, and using a long chopper. The irrigation from the AC main tunnel is closed. Using the long chopper, I'm doing a horizontal chop. The cataract is pretty soft, but I'm able to go all the way to the posterior plate and have two heminucleuses. Now we do a lateral chop, bringing up from the back using the long chopper 1/4, and using this kuatera Phacomachine, it's very easy to aspirate that piece out. The vacuum is set up at 700, but you can adjust it using the foot pedal as much as you want. Of course, you're not going to push it all the way down in these soft cases. And half of the nucleus is out, rotating the nucleus inside the bag, and then do a horizontal chop on this nucleus, on this half of the nucleus, using the phaco needle just mechanically to hold the piece in place, and then it's very easy to aspirate using the chopper to feed the quarter into the phaco tip, and the last quadrant is removed out of the eye. Pretty easy aspirating it. And then I use this phaco tip also to clean up the bag and do the cortical removal, switching the Phacomachine into the cortical aspiration and gently maneuver the cortex into the middle safe zone, and then aspirate the pieces one by one. It's very important to not rush this part of the surgery, and take your time a little bit and be gentle on the foot pedal. Just engage a little bit, take the pieces on the central zone, and then continuing aspiration it a little bit more. And we can see that still a lot of viscoelastic left at the end of this phaco aspiration. Injecting the trifocal IOL inside the bag is very easy task to do, and then I'm using aspiration cannula to aspirate the cortex, and then rotating a little bit the IOL inside the bag and place it into the position, center it a little bit, and that's the end of the case. Washing out any viscoelastic, pushing down the iris root to break the anterior synechia. This will take care of the IOP post-op, injecting some IOCOL, and that's the end of the case. Thank you for your attention. Hope this will help in your practice also.